नहीं वो
डॉक्टर बगेजा
मेरा माइक्रोसॉफ्ट करप्ट था थोड़ा तो आज चल नहीं रहा.
All right. Just introduce them.
Yeah. So Chetan will say okay, and then I'll give a pause of 10 seconds.
We are live now, doctor.
Okay, thank you. So good evening, everyone. Welcome you all from Delhi Orthopaedic Association to the Sunday evening webinars, 6 to 8 p.m. We've been doing it from December. We did have a break of a couple of weeks with festivities, the Independence Day and Raksha Bandhan, the Bone and Joint Week, and we are back here again with an amazing evening today. This initiative is to continue medical education with the practicing orthopedic surgeons as well as the residents who hook on to this evening and learn from the best who are available around on that particular topic. So we do 2 or 3 type of events. One is the master class, which focuses on a particular topic, and we take you from A to Z in that. And then the grand rounds. Again, we focus on a particular, say, disease or a pathology or a fracture, like a calcaneal fracture, and we discuss cases. That's the grand round. And then we have our quarterly events in which we have various themes. So today evening, we have a masterclass on unicondylar knee replacement, which is a very, very specialized area, I feel. There would be a lot of knee replacement surgeons, but out of them, how many would be doing unicondylars? I know would be very few. So an interesting topic, an evolving topic, a lot of debates, a lot of competitors to this technique, but I'm sure with the faculty we have today, a lot of our queries and a lot of our understanding will have a new morning to visit. And we have Dr. Pardeep Bageja, who is a senior consultant in Sir Gangaram Hospital and the Vice President of Delhi Orthopaedic Association and the Joint Secretary of Indian Orthopaedic Association. He would be the expert moderator for today, and I hand it over to him to detail upon the faculty we have and take the webinar further. Thank you very much.
Thank you, Dr. Maini, for the kind words. And today meeting, as briefed by Dr. Maini, is on UKR, and we have got today national as well as international faculty. From national, we have got Dr. Harish Ghoota from Faridabad, Escorts. Welcome, Dr. Harish. And
hello.
We have Dr. Yash Gulati from Apollo Hospital. Good evening, sir.
Hello, good evening.
And we have got Dr. Kartik Shukla from Ahmedabad. Good evening, sir, Dr. Kartik. And Dr. Sanjiv Manjure, I welcome him. He's from England, from Luton Dunstable. He was my ex-boss. I worked with him for a few months. And I'll briefly share my screen and explain about them, about the experience of my faculty. Dr. Maini, will you stop your share, please? Dr. Maini, sir?
My sharing is stopped.
Stopped.
Chetan, can you allow Dr. Bageja to share the screen?
Yeah, 1 second. So he's loud.
Try again, Dr. Bageja.
Yeah.
Just click on the PowerPoint. It is there on the down minimized area. No, leave the Zoom. Just come down to the base of your screen. There's the PowerPoint link. Click that. Yeah.
So today is a master class, UKR, and it is under the banner of DOA, and our president, Dr. Lalit Maini, myself, Dr. Bageja, and Dr. Hitesh Lal is the secretary. The first faculty is Dr. Yash Gulati. Sir is from Apollo Hospital, and Sir is Padma Shri National Awardee, Dr. B.C. Roy National Awardee, and he's practicing replacement for last, I think, 25 to 30 years now, and his main interest in partial knee replacement. And I hope he will deliver some good message to us, and mainly in the surgical technique part. Thank you, Dr. Gulati, for accepting my invite.
Thank you.
Another faculty from UK, Dr. Sanjiv Manjure. Good evening, sir. And he's presently working in Bedfordshire Hospital, NHS Trust, University Hospital. Sir is right now the consultant there, as well as the Deputy Director of Surgical Examination, Royal College of Surgeons, Glasgow, and is a regional advisor of East of England. Welcome, Dr. Manjure. And sir has got main interest in hip and knee replacement surgery, revision knee surgeries, and knee ligament surgeries. And the next faculty is from Faridabad Escort, Dr. Harish Ghoota. He's the additional director, orthopedics and joint replacement in Faridabad, and he specialized in navigated knee and hip replacement surgeries. Trained for partial knee replacement surgeries at Newfield Orthopaedic Center, Oxford, England. He performing around 800 joint surgery in a year. He's a national and international faculty in various conferences and cadaveric courses. He introduced the concept of partial knee replacement as a daycare surgery in India on April 15, 17. Welcome, Dr. Harish.
Thank you, sir. Thank you.
It will be great evening with us. And another faculty from Ahmedabad, Dr. Kartik Shukla. Sir had done the medical education from BJ Medical College, Ahmedabad. 16 years of experience in arthroplasty, field of interest, partial knee and computer-assisted orthopedic surgeries, hip and knee revision surgeries. He performed more than 2,000 UKR surgeries, and presently heading a department of SGP Holistic Hospital, Ahmedabad, and is a senior consultant, Gertson Orthopedic Clinic. Welcome, Dr. Kartik.
Thank you, sir.
And myself working in Gangaram Hospital as a senior consultant with main interest in trauma and replacement. It's my humble request to all the faculties to keep the talk up to 50 minutes so that we have enough time for discussion, question and answers. Thank you. So I'm going to start the session today with the topic of indication in UKR. Chetan, can you help me, please?
Yes, please tell me, doctor.
My presentation, I can't see.
Can you close your presentation once and then open it from the desktop?
1 minute. Can you see that now?
Not yet, sir.
It is. I can see it on my desktop right now.
But you have not clicked on the share screen, I guess.
Chetan, I can't go understand where is my Zoom is gone from here.
And sir, can you leave the meeting once and rejoin?
Yeah, I can.
Is there any Zoom available?
Yeah.
So let me just ask an open question to maybe anyone who wants to take it. I'm sure all of you started with total knees. So what took you into partial knees? Maybe you can share your journey. Why? Till Pradeep is coming back.
I think I'll take it because I think I'm the youngest entrant into this field. So maybe, and then others can take it because I think, John Goodfellow was my examiner.
As expected,
Well,
Pradeep is
no.
back. Pradeep is back.
Okay, great.
Okay, Pradeep, all yours. Pradeep, are you muted? Pradeep, I think you're muted. You will have to unmute yourself. Chetan, can you unmute Dr. Pradeep?
Yeah, I've.
Can you hear me, sir?
Yes, now we can hear you. Go back to your first slide. Start from there. We couldn't hear you.
Something is not moving. Chetan?
It's not moving.
Why?
Just press again. At times the file is heavy.
So can you please scroll your mouse pointer at the left hand side of the screen?
Here?
Yeah. Can you see any arrows here?
Yeah, it's moving now.
Yeah.
It's moving now, yeah.
Yeah, okay. You can start now.
So, sorry for delay. And today I'm starting the session with the topic of Oxford or UKR indication and contraindications. In Oxford knee, whenever you're planning the counseling of patient or the cons of the Oxford knee and UKR is must. Consent to be taken for TKR also before proceeding. Inventory of TKR is must in the OT in case plan change on intra-op findings. This is very important. Always take into mind before going to OT. Oxford knee, unique compartmental knee, UK is an attractive alternative to total knee replacement for patient with isolated medial knee arthritis. So this medial knee arthritis, for which this implant is came up. Biomechanics of UK is more and compared with that of total knee arthroplasty. The Oxford good fellow and engineer corner, the femur was spherical, tibia was flat, and bearing was mobile, unconstrained, fully congruent in all positions. This articulation maintained unchanged since 1976. What the advantage of UKR is it's a less invasive surgical exposure, preservation of native bone stock, retention of cruciate ligaments, lower perioperative morbidity, enhanced post-operative recovery, and improved patient satisfaction. The indication is isolated anteromedial osteoarthritis or SOK, spontaneous osteonecrosis of the knee joint. This we are talking, isolated anteromedial OA, which I will discuss in further slides. How to diagnose it? That is anteromedial OA diagnosis criteria. Medial OA with bone to bone. ACL and MCL should be functionally intact. There should be full thickness cartilage in the lateral compartment, which can be confirmed from pre-op X-ray and as well as it can be confirmed intra-op during surgery also. There must be full thickness cartilage loss on both sides of medial compartment with bone-to-bone contact, which confirmed by pre-op X-ray. Sometimes people prefer arthroscopy, or smart surgeons always do even intra-op also. If you see the three biscuits, you can see anterior, we want this much, loss, bone-to-bone, 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 but the preserved posterior cartilage in all the three slides. We want pre-op ACL should be okay. ACL must be functionally intact. PCL is not affected in OA, but ACL is damaged and is sometimes absent. ACL deficient knee is contraindicated for UKR. And again, I'm repeating, on the lateral, there should be full thickness lateral cartilage. Lateral compartment should be well preserved with an intact meniscus and full thickness of the articular cartilage. Varus deformity should be correctable. Varus deformity should be less than 15 degree. Flexion deformity should be less than 15 degree. And if it is more than 15 degree, that means ACL is ruptured or not well. So this is one of the slide which shows medial OA, preserved posterior cartilage, and functionally intact ACL and full thickness lateral cartilage. When the ACL is damaged or insufficient, there is a posterior bone loss can be seen on lateral X-ray. There is a mediolateral subluxation that doesn't correct on valgus stress. So in AMOA case selection, there is a 4 diagnostic criteria: medial OA bone to bone, ACL should be okay, MCL functionally normal, and lateral compartment full thickness cartilage, so functionally normal. And there are a lot of things in discussion for MRI, for diagnostic or arthroscopy. The best is simple X-rays, that is Rosenberg X-ray, which is done. And if you are not sure sometime, like 70-30, you can even confirm intra-op before proceeding for final surgery. It is also available Zimmer Biomed software, which is not there in our side, which can be used for the same criteria to be understand before planning for UKR. See the same ACL, and sometime we can plan for we need skyline views for the patellofemoral joint assessment. In that, PF is not contraindicated, provided there is not severe damage to the lateral part of the patellofemoral joint with bone loss, grooving, or subluxation. Otherwise, medial is acceptable, but not lateral one. If this is scenario on skyline view, we can't go for UKR. The contraindications are: it's an inflammatory arthropathy, previous STO with overcorrection, sepsis, cruciate ligament lesion, medial or lateral subluxation, usually associated with torn ACL, tibial or femoral shaft deformity, flexion contracture more than 15 degree. Oxford knee is not contraindicated for lateral compartment replacement. Neither patient age, weight, or activity levels are contraindication, nor is the presence of chondrocalcinosis. Patient to be cautioned, patient to be counseled always. Decision can be changed intra-op depending on ACL integrity and lateral compartment status, and TKI implant should always kept ready in case decision change. Thank you.
So thanks, Dr. Bageja, for that introduction to the topic. Am I audible there?
Yes, sir. Any questions?
So we'd actually raised a informal sort of a question just before you started, and open it to all the faculty that I'm sure all of you were total knee replacement surgeons and you graduated to Unicondylar. So can you share your experience, that why and how that gives a motivation to the delegates who are listening and who are still not Unicondylar surgeons. So any of you can take it. Dr. Yash?
Okay. I was actually, John Goodfellow was my examiner when I did my MCH. And he had actually, in 1988, they had started doing these unicondylars. And I was very fascinated by that concept at that time. But somehow this wasn't popular in our country. My class fellow Harish in Nagpur started doing unicondylars in Nagpur. But there are such few people doing it that every time there was a problem with this surgery, all the surgeons pounced on him and they, misinformed their patients that actually Hari stopped doing uni because of that reason. But then with the improved instrumentation and with improved results and with the workshops being conducted in our country, I felt very encouraged because I always was very much encouraged by this kind of surgery because it is physiological, it gives wonderful results, unbelievable results. And once all this was available, then I thought it was time to start that again. So that was the reason why I got into it about 4 years ago, and I'm very happy that I got into it.
So I think the first step is exposure to the particular technique, and that's what you got, and then you got initiated. And it's great that we are doing the same through this webinar. So Pradeep, I think we can take the next talk, and then we can keep coming back to this question with each faculty.
Yeah, thank you, sir. So I invite Dr. Yash Gulati for the next talk. Sir will be speaking on the surgical techniques, tips and tricks in UKR. Dr. Yash Gulati, sir.
Okay, thank you for your invitation. And here, where are my slides? Here is this. Okay, and slideshow from the beginning. And these bars will continue. So can you see that?
Yeah, it's clear and you're audible.
Okay, great. Thank you for your invitation and thanks for giving me this opportunity. And as I said, I am really wedded to this idea of unicondylar knee orthoplasty because it's wonderful. Why is it not moving? Okay. Can this can be minimized? No? Wait a minute. Sorry. Can this be minimized? This picture that I see. Lalit, this bar on the right side.
On the top of the pictures, there is a single bar, a double bar, and a multiple bar. Just click the single bar, it will minimize.
Okay, great. Yeah, it disturbs. All right. Now, for getting a successful result from unicondylar knee orthoplasty, the first criteria is to have the proper case selection because that is critical. If the case is not right, then the results are not going to be good. And as Pradeep just said, I'm just going to put this slide for the sake of completion. These are the criteria: full thickness, medial loss, and functional ACL, and a good lateral joint. An ulcer on the medial part of the lateral condyle of the femur does not matter. That is okay. Medial petrofemoral OA does not matter because that will be taken care of. It will be offloaded after the surgery. And obviously, inflammatory arthropathy is a no-no. And we all know how to, just by X-rays, find out whether the ACL is intact and whether it is indeed an anteromedial OA. So I will not go into the detail. The principle of the surgery are that when we do total knee arthroplasty, it's a different ball game. We are trying to create a square. The lateral collateral ligament, which is normally a little lax, we tighten that also. And we need to release ligaments from the medial side to make it a rectangle space in case of contracted medial collateral ligament. But in unicondylar knee orthoplasty, we do not touch the ligaments. No releases at all because we presume that medial collateral ligament, although appears contracted because of the varus, but is actually not contracted. It is actually, it's got normal length, it will regain in length. And just as in a normal knee, lateral collateral ligament is a little lax, the medial collateral ligament is just about tight, and that's exactly what is the aim to achieve when we are doing unicondylar knee orthoplasty. And also, other principle is that in total knee orthoplasty, for example, I use navigation, computer, this and that, and we are so paranoid about getting, the alignment within 3 degrees of that weight-bearing line. But that doesn't hold true when we are doing unicondylar knee orthoplasty because of the concept we'll talk about in a little while. So that is another difference. And the coronal plane alignment in unicondylar knee arthroplasty is actually determined by the thickness of the bearing that we put in, and is not determined by the cuts. So the thicker the insert we put, the more towards valgus it will go. But obviously we don't want to go to valgus. We just want to come back to the previous pre-disease varus, because we don't want to do anything more than that. We do not want to load the lateral compartment more than the normal lateral compartment. So that is the principle. So we definitely don't want to create valgus, and we want to come back to the pre-disease normal little 3-degree varus that patients usually have in India. And another principle is that because this femoral component is part of a sphere, it does not matter if it is tilted this way or that way by about 10 degrees. So it's very forgiving that way. And so we don't have to be paranoid about it like in total knee orthoplasty. So these are the principles we keep in mind. But having said that, unicondylar knee orthoplasty is a technically challenging operation, because if it goes wrong at any step in flexion extension gap, and especially if the extension gap is more, the situation may actually be irretrievable. And if we happen to damage the medial collateral ligament, we have to abandon the operation. So these things are, it's a technically more challenging surgery as compared to total knee orthoplasty. So how do we position the patient? There are special leg holders available, or we can use normal table. I started using leg holder, but the problem in India is that some of the patients are so short and fat that it becomes an issue. So I've stopped using leg holder and now I use a normal table. When we go on the tibial side, our goal is to do as little resection as possible. The resection should be only as much as we'll do it in total knee. That is about 1 or 2 millimeters below the worn out surface, not more than that. And we should utilize as much surface area of the medial tibial plateau as possible, because we do not want to load the center, because then it will give way or it will fracture. So use the periphery, which is the strongest point in the medial tibial plateau. Now for doing that, we have special instruments like spoons or the stylus or the clamps, and these help us in positioning the jig, and the spoon will let us position the jig in a proper position. It will let us cut the thing to a particular thickness as we want. So these are important things, and spoon actually sits on the posterior hump, as you know, which is available. But if there is too much of bone loss, if there is more varus, then this spoon, if it sits into that ditch, we may end up cutting more bone. So the spoons are available in different thicknesses. If there is more bone loss, then you use a thicker spoon so that we have to cut less bone, because as I said, it's critical that we cut as little bone on the tibia as possible and try not to recut if possible. In fact, in my life, I've never recut the tibia again. So, and we have this G clamps. They are available for aiming at 3 millimeter or 4 millimeter meniscus insert. In small and extra small, always 3. In bigger, 4. The beginners may be 4, but I always aim at 3. I mean, 90% of the times I'll put 3. In India, they are small or medium mostly, so it's okay. I always aim at 3. And these are the different G clamps that are available, but you can aim at 4 if you like. Another important point is that when we are trying to plan the vertical cut, that is going to determine where our component tibial plate is going to sit. So, and the plane in which we cut, that vertical cut will tell us which rotation is going to sit. So it's very important that it should be just kissing the anterior cruciate ligament. In fact, we should take off a few fibers of anterior cruciate ligament, and that will be the correct cut. And the direction of cut should be the direction of the movement of the tibia when we flex it, or aiming towards anterior superior leg spine. But that's very difficult to determine during surgery. So the aiming at the movement of the leg is the best guide. And always this line will point a little bit lateral. It will not be straight. It will be pointing a little bit towards lateral side. If it is pointing straight, we are wrong. Also, never lift one's hand when one is cutting, because if we cut posterior cortex, there are chances of fracture. Always drop the hand, drop the hand, drop the hand. Never lift the hand because that will cause damage. Similarly, for horizontal cut, where there is a slotted jig available, you can do it through that. And again, don't lift your hand, drop your hand all the time. And then remove this biscuit. Last part may be cut with osteotome or the saw blade kept longitudinally. Don't go towards medial collateral ligament, because that is one thing we do not want to cut, and use a Z retractor to retract the ligament away from the saw. That is very, very important. And even initially, when we remove a bit of meniscus, we should be very careful. On the femoral side, you see where the hole is for putting the femoral guide in. This is much more medial than the normal total knee, and this is in the line of the lateral wall of the medial condyle, about 1 centimeter above the posterior cruciate ligament. And then just put the rod in, and don't ever hammer it, because sometimes if the direction is wrong, we may end up perforating the cortex, and that's what we don't want to do. And there are these links available, and this will help us position in a particular proper angle of flexion and valgus. And sometime, but in India, the patients are small, and this link is of the same size for small and bigger patients. That is a drawback in this instrumentation. So sometimes you have to struggle and juggle a little bit, push the things here and leave medial and lateral to bring these bollards right in the middle of the medial condyle, because the holes must come in line of the the midline of the medial condyle. Otherwise, the seating will be a problem. So that's how it is, and we make these holes. These are two critical steps. One is the tibial cut. Once that is done, 70% of operation is over. And once these two holes are made in proper place, then about 90% of operation is over. Rest is all mechanics, and it will carry on. So that's done, and then you put the jig, femoral cutting jig. Then you divide that, and make sure when we are cutting it that the meniscus will not be hitting the wall. So that should be fairly lateral, the cut in vertical, as we discussed in the beginning. And then we position this femoral cutting guide and cut the posterior aspect of the femur, and that the fragment which comes out should be the same thickness as the thickness of the final femoral implant. So it is only to substitute that, no more, no less. And then with the zero spigot, we just fashion it. We are not cutting more distally. This is just to fashion it. Then do the trials and flexion extension gap. Now there is, I think one has to be very careful in doing that. The flexion, it should just go with 2 fingers. And then in extension, I think in one slide it will be difficult to understand, but if number one, the spoon doesn't go inside, then you have to just, for example, it was 3 other side and one did not go, then you have to cut 3. You take a 3 spigot. If say 1 is going easily, then you do 2. So there is a mathematical calculation, and in even after all this reaming, if it is a mismatch, then suppose we want to increase by 1, then we will just do, instead of 3, 4. It is confusing in a talk, but once you see the instrumentation, it will be easier to understand. Once it is done that, then you have to do the impingement, removal of this impingement thing, because that will prevent patellofemoral. This was a Swedish surgeon who suggested it to the Oxford group that why don't you do that? That will take away the problems of patellar impingement. And that is why now the medial patellofemoral OA doesn't matter, because there's no impingement onto the implant in that. So I made a small video. I think we'll maybe emphasize 1 or 2 more points in the video, and if there are questions, we'll be able to answer them. So, as I said, correct choice of the patient, that is critical. This is the initial days when I used to use the leg holder. Then I think I'll have to stop it in between. The medial parapatellar incision, as little, just above the superior polar patella to tibial tuberosity. Some people make it even smaller. They slide the window up and down. I don't do that, because why get messy just for 1 centimeter? I don't do that. Then we will take out the fat pad, which is coming in the way. And once we have done that, we will inspect the anterior cruciate ligament with a hook. And then also we'll inspect the lateral condyle. As you can see, the lateral condyle is good. You can even tap it. Once you've done that, then the next step will be to remove osteophytes in the intercondylar notch, the lateral as well as medial osteophyte. And there is sometimes a osteophyte in front of the ACL insertion called anvil osteophyte. Once we remove that, if there was any flexion deformity problem, that will disappear. This is removing the osteophytes, and this is the spoon. Now, once we put the spoon in, now I will just show you that once the spoon is put in, we tilt it one way and the other. So it should move 10 to 15 degrees either side, and there should be a gap between the femoral condyle and the spoon, normally where the cartilage would have been. If it is kissing the medial condyle, then it is too small. So this will also help us assess the size and the whether or not this is about little. It should be little lax. So once we have done that, you see, I can move it 10 degrees both sides. Once we've done that, we attach the jig to this, and the jig should be sitting nicely on the medial side. Medial side exposure is not too much, only enough to keep this jig touching on this. Put the G clamp and then bring this pedal down, and then pin it either with one pin, which is the middle one. If it is not looking very stable, then put the more lateral pin. Never put a medial pin because we don't want to have effect. See the vertical cut, how this blade is not looking straight. It goes a little bit towards the lateral side. So that's the right thing. And once it is done, then the horizontal cut. After horizontal cut, you take this biscuit out, last part with the osteotome, and then you measure it with the opposite side trial. And that will give you the size. Once that has been done, then as you can see, the site of the hole that is to be made in line with the medial, the lateral wall of the medial condyle, and then you will put, never hammer it, just with the hand, push it in, and with that, we'll put the jig in. This jig should go in easily. If it is going tight, that means there is a problem. Our cut was not right. This should go very comfortably. And then we attach the link to that, and then we will look into the holes that they are in the center. Sometimes it's difficult to see these holes. So what I normally do is I just make a small little burr with this drill on both the holes, and then I take it out and I then inspect it and see, yeah, they're in the center. I put it back and then I complete this. Otherwise, it is very difficult to see the line through the holes, especially when the bone is so sclerotic. The line is actually very difficult to see. And these holes are made. Once these holes are made, then you can relax. And then, as I said, with zero spigot followed by whatever the measurement was, you do that. And this is the posterior cut. Posterior cut made, and then followed by the zero spigot, shaping it, then measuring the gaps, flexion extension gaps here. This is in flexion. See, it should go very easily. In the extension, it's not going, so you decide which spigot to use, and then you ream it, mill it. And this is a very beautiful instrument, this milling, and it just takes away just the right amount of bone that it will make a collar, and then collar will be taken off. And once that is done, then you do a trial again. That is in flexion. See, it's going nicely. In extension, also in about 20 degree of flexion, it should go as easily. Don't have to push it hard. Once that goes in, that's fine. And then you can do the final with 2 fingers only. And then the anti-impingement cut, that bone will be removed here, followed by the preparation of the tibial plateau will make a slot. See how much this takes away a lot of bone from here, so that prevents, and then the posterior osteophyte can be removed through this special osteotome which go through that hook. And now this hook is important. We want to make sure that this hook is on the posterior wall. We don't want to push this component too far posterior. We don't want to have a breach in the posterior cortex. No way we want to have a breach there, because that will cause a fracture. So once that has been done, we sure that it is away from the posterior cortex. You pin it gently, and with the toothbrush saw, you create a slot. And now there will be 2 small thin, with this you make sure that you take away a bone from anterior, because mostly this anterior bone is left behind, and then the whole component is shifted posteriorly. So it's very, very important to make sure the whole slot is cleared. First with the uncemented slot maker, secondly with the cemented slot maker. And then once that is done, then we are ready for making small holes into the femoral condyle, inject our cocktail if you normally do that, which I do, and inject the Trenexa if you normally do in your practice. And then we are ready for the trial with the trial meniscus. And this should again go easily. Once that is done, you check it that it's not impinging medially laterally. See that the tibial component is sitting in the right place. If it is too medial or too lateral, you can put a saw blade there so that you can bring it more medially so that the periphery is utilized. And once that is done, you put cement on that, very thin layer of cement, because we sometimes have difficulty removing posterior cement. So thin layer, and this cement the tibial component, and this cement into the 6 millimeter hole is pushed with a spigot 2-3 times so that it goes in, and you can make a small, put a suction in the small hole so that there is no blood there. And once that is done, then the component is fitted in, hammered with a very light hammer. Never use a heavy hammer, never ever, because that will cause fractures. Only light hammer. Remove the cement, especially posteriorly, and these components actually act like mirrors. You can see the cement in the mirror. And then you put this component once the cement is. I normally put this bearing right in the beginning. I don't wait for that. And once that is done, you can, if you use a tourniquet, you can remove it and just close the wound. I don't use a drain. Those who use a drain can use a drain. So these are, say, bilateral knees. In fact, only this Wednesday, I did a bilateral uni for a very, very, very important leader of our country. And he walked next day without any aid. And today he's gone home. Just walked to his car and got into his car. He couldn't believe that, such a result is possible. So uni can give that kind of a result. For example, here, this is what we want, forward bending, walking, and sitting cross-legged is allowed in this if required. And this gentleman, for example, this man plays golf and he can run. So this is what we expect from uni. If the choice is correct, patient selection is right, and technically it's done right, that's exactly what we expect, and that's what can be achieved. Thank you for listening and watching. Thank you.
Thank you so much, sir. Dr. Gulati, sir, for a wonderful talk and the presentation. We have got 2 questions on the chat box. In the patient workup, stress valgus X-ray and MR is mandatory.
Yes,
Dr. Gulati.
Yes, always do. Always. And I don't do MRI. I don't do arthroscopy. But stress X-ray in all the patients, we always do. And in fact, I have trained 2 or 3 radiographers in our hospital, and many a time I go myself, because to do a proper stress X-ray is an art. You have to hold the knee in 15 degree of flexion. The tube has to be directed 15 degrees so that it is parallel to the knee. The hands have to be kept at a proper place to give proper stress. Because sometimes, if it is not done properly, it gives a very erroneous impression. But yes, in all the cases, we do stress X-rays.
One more question. Is there basket or implant choices in UKR also as in T? Like as we have options in TKR, like we have got UKR also, other than Oxford knee, we are doing something else. Only Oxford.
Well, there are other company implants also available, especially the fixed bearing implants. Other companies are also available. But I'm very happy with this implant, so I have not looked for other implants.
For a beginner, what do you advise? Fixed bearing or mobile bearing like Oxford?
No, mobile bearing is very, very forgiving. All those contraindications, the Cousin and Scott paper, which are there with fixed bearing are gone, heavy weight, and, many other things are not contraindications anymore. So I think mobile bearing it's excellent. The results are unbelievable. Unbelievable results.
Right. And thank you so much. What is the protocol for your mobilization on day 1?
Oh, they get up in the evening, same evening. If it is done the first case, because we put no drains, nothing, they walk in the evening. In fact, this leader I'm telling you, he went to the toilet same day, same evening, and next day, like today, he went without a stick, walked to his car. It was done on this Wednesday, and today he's walked his car, climbed into his own car. I mean, this is a wonderful operation, unique.
Right.
I would really encourage youngsters to take this up.
Right. Thank you, Dr. Gulati. Any question from faculty or any comment from faculty? Thank you, sir. We'll come back again to you at the end of the session. Thank you so much, sir.
Thank
So
you.
next, please stop sharing, sir. Dr. Gulati, sir. The next talk will be by Dr. Harish Ghoota. He'll be speaking on tips and tricks to avoid complication in UKR Oxford knee. Dr. Harish.
यार ये पहले भी मैंने पूछा था
Hello.
of sharing.
So ऊपर होगा sir. हाँ जी. Thank you. Yes, Dr. Harish.
आ गया ना, so it's okay.
Yes, sir. Yes, sir. Yes, sir.
Good evening, everybody. I'm unable to share now.
You were able to
Is it
look at your
okay now?
slides. It's coming. It's coming.
We can see that, sir.
Yeah, we can. Just click the slideshow.
The slideshow tab is not
Yeah,
coming.
that's right. Go back.
Okay.
Actually,
Yes.
you should have. Yeah, that's perfect. Yeah.
Good evening, everybody. Thank you, Dr. Yash Gulati, sir. Thank you to the organizers for inviting us for a wonderful talk today. So I'll be talking about the complications in a UKR surgery and some of the precautions by which we can avoid those complications. Since we know it's a very like a minimally invasive surgery, the surgeon has to work from a very small incision, and that too we are not allowed to release the soft tissues, so we have to be very precise in our bone cuts so that the joint can function well, and that's the basic philosophy behind the surgery. So if you look at the various complications associated with medial unicondylar surgery, is like there is progression on the lateral compartment, there can be bearing dislocation, and an unexplained pain even with a perfect surgery. Now these are the major three complications. The other rare complications are infection, loosening, or operative fracture. The thing to like consider is that polywear and PFJ are not a major compound. They don't play a major role in it. So they are very negligible. So if you look at the bearing dislocation, most of the surgeons, they are fearful that the bearing is like lying loose, it's not fixed, it will dislocate. And that's the basic fear when we start a unicondylar operation with a mobile bearing prosthesis. Now to tell you, the incidence of dislocation is about 0.5%. That's very negligible with the advent of microplasty instruments and the reproduction of a precise surgery. The incidence of bearing dislocation has decreased a lot. Although it's maybe there with the beginners, and it usually occurs when the patient is flexing or extending the knee when he is not weight bearing. Sometimes it can be missed because the knee might go, the varus might increase, and the patient can bear a weight as well. So in any of these situations, when there is a twisting of the knee and the patient comes with pain, then the diagnosis is usually done by way of a X-rays only. So what are the causes of bearing dislocation? If you look at the philosophy of the surgery, the ligaments has to be properly tensioned. So if there is a distraction or displacement of the components, it may cause a bearing dislocation. If the bearing is accurately tensioned between the components by way of the tensioned ligaments, they don't dislocate. So if there is a flexion and extension mismatch, which is an inaccurate balance, it may cause a bearing dislocation. Sometimes what happens during the surgery, the MCL may get overstretched or there is damage to the cruciates, that also cause a loosened gap, and that can cause a bearing dislocation. Now, what happens? There may be an internal displacement of the bearing itself. So, if there is an impingement by way of a retained cement on the posterior aspect of tibia, it pushes the bearing outward. So, that's an impingement because of the cement. And the same may happen by way of a bony impingement anteriorly. And that was the reason the anti-impingement guide was introduced, as Dr. Gulati has already mentioned. With the advent of the anterior impingement guide, the anterior impingement is almost gone. So this is the bearing. It was the bearing before the microplasty instrument. So it was a universal bearing. It was the same bearing for left and right sides. Now, if you look at this, the posterior side is 3 mm and the anterior is 5 mm. So anterior displacement is usually commoner in comparison to the posterior dislocation. And the side to side measurement is uniform. So it's a part of the sphere, and the circumference is corresponding to the femoral circumference. So if a dislocation occurs, the treatment is we can open the knee joint, remove the bearing. The anterior dislocation or the anterior displacement is like easier to remove, and the posterior is quite difficult. Now we have to check what is the cause. Is it a loosening of the ligaments, or there is malpositioning of the components, or there is impingement of the cement or the anterior bone. If the bearing is loose, then we can put a slightly higher bearing. The rest of the causes usually requires a revision of the surgery. The revision can be done by way of a TKR or a fixed bearing unicondylar, which is usually very difficult to put in, and in most of the cases, a TKR is the answer to such a problem. Now, sometimes what happens during the surgery and after the surgery, we may have a tibial plateau fracture. Now, the reason is when we are going for a vertical cut, the cut may get too low. So, we can either damage the posterior cortex, or we can remove a lot of tibia so that the cut comes quite close to the medial cortex of tibia, and that causes a relative weakening and a stress riser, and that is usually the cause of a tibial plateau fracture. If it is like seen during the surgery, we can deal it better. If it happens after the surgery, then the treatment is usually very difficult. Now, to avoid this, we have to use a keel cut saw, and we have to use the largest possible tibia which is possible. Like the medial lateral dimension of the tibia has to be the largest one, and it should sit on the medial cortical tibia. The tibia depth should be as less as possible, because then you will be sitting your tibia on a harder bone. So just avoid deep cut and avoid your vertical cut to go distally. And always use a very light hammer. They have provided a 100 gram hammer with the instrument. Always use the same hammer, because hitting with a hard hammer or a heavier hammer is usually the cause of such a fracture in the per-op patient. Now, coming to the treatment part, usually the deep MCL is attached to the lower tibia, and the the deep MCL is attached to the proximal tibia, and the superficial is attached to the deeper tibia. In such a case, the bearing is usually stable, and we can fix the fracture by way of a plate or by way of some screws, and they do well. The only thing which we need to see is that the flexion and extension gap has to be balanced. The fracture should be reduced to its anatomical position. So if it is reduced to the normal position, then usually these patients, they do well even after the fixation of periprosthetic fracture. Now, coming to lateral OA, the progression of OA can be because of several reasons. The most common reason which we see in our Indian clinical practice is an overstuffing of the medial compartment. So that means if we take a less amount of tibial cut and we are putting a bigger insert, that creates a overstuffing or more pressure on the lateral side. So the knee may go into valgus and the weight bearing side goes more towards the lateral compartment, and that causes a lateral progression. The second common thing which we see is either a reappearance or a recurrence of an inflammatory arthritis after the surgery, like the patient was negative for rheumatoid arthritis when the surgery was done, but after 7 to 8 years of time or 10 years of time, there is a zero conversion into rheumatoid arthritis. So these are the basic two scenarios when we see a progression of the lateral arthritis in such a cases. So usually when it is like laterally it is progressed, we cannot do it. We cannot manage the patient by conservative methods. We have to resort to operative means. One thing which is very important here, which I would like to mention is during the surgery we have to put a curly wurly retractor, and that is actually separating the deep MCL from the medial tibia. So when we are taking the horizontal tibial cut, we have to protect the MCL. Sometimes you in the beginning in your initial surgeries you may damage the deep MCL, and that causes a relative widening of the medial gap, and that is usually the cause of further lateral progression of the OA. So be very gentle with your surgery and just take care, be very precautious of the deep fibers of MCL. You have to protect it, and the tibia should not protrude a lot from the medial cortical edge, because that way also it will cause a attenuation of the fibers of MCL. Once you have a lateral progression of osteoarthritis, then you can either convert it into a TKR, which is usually the answer to such a solution. The second thing is you can add a lateral unicondylar prosthesis, which is usually reserved for experienced surgeons. Now, this is a curly wurly retractor which Dr. Gulati has already shown it to you, and it is placed in between the medial cortex of tibia and the MCL. So when we are taking the horizontal cut, the saw should strike the retractor. It should not strike the MCL, and that's how deep fibers are protected. If they are gone, then you should abandon the surgery in favor of a total knee replacement. Now, one more thing which I would like to emphasize to prevent the overstuffing is you should always use a G-clamp. You should not take a freehand proximal tibial cut, because if you do it this way, then you will be ignoring the tension of the ligaments and you'll end up putting a bigger bearing for a smaller joint. So you should always combine the things together so that you can have an adequate intra-articular gap for either 3 mm or 4 mm poly bearing. Now, these are very useful instruments. If you look at the instruments, this is known as femoral drill guide. They have two like paws which you can either increase or decrease. You can see that there are markings, like on the right side it is 4, 6 and 8. On the left side it is 3, 5, 7 and 9. So these are the millimeters by which you distract the two jaws of this drill guide. If you are taking 3 mm poly, if you have decided to put a 3 mm poly, you should keep it at 3. If you are deciding to use a 4 mm poly, then you will keep it at 4. And this should go in and come out with two of your fingers, like a pincer grasp. So if you are holding a pen, just hold this jig like this and go in and come out with relatively easy, without putting any force to either push or pull the zig out. Now, coming to the implant loosening, the diagnosis of loosened implant is very difficult in case of a unicondylar knee replacement. The reason is that the radiolucencies are not very well seen, and they are not very well assessed by most of the surgeons. So the diagnosis is usually by way of getting some stress views and seeing whether there is a migration, or getting a accurately aligned x-ray so that you can just look at beneath the implant and you can differentiate between physiological and pathological radiolucencies of the implant. So if your component is migrating, you have a pathological lucency, then that definitely requires an assessment for a loosened implant. If you look at these X-rays, you can see the femoral component is loosened apart. So the alignment of femoral implant with femoral bone is relatively different in different positions of the knee. So there is a definite migration, and that shows that there is loosening of the femoral implant. Now, if you look at the same X-rays, these are the flexion and extension views, and if you can see, the peg of the femoral implant is like going in and out of these X-rays. So you can very well appreciate that the femur is loose, and during extension it goes proximally, and when you flex it, the implant is coming out of the bone. Now, what happens? Why femoral loosening happens? The most important reason is that there can be inaccurate cuts or poor cementing. So 6 mm hole should be properly pressurized and cemented, and the cuts. Now, there is a recommendation to take proper femoral cuts. The recommendation is you should always use the proper saw blade. The thickness has to be just snugly fitting through the posterior guide. Then the blade has to be perfectly parallel. So you have to drop your saw down when you are cutting the posterior femur. And while cementing, you should pressurize the femoral implant when the knee is at 45 degrees of flexion. So that creates a force which is perpendicular to the femoral implant. And once it is loosened, the treatment is only and only revision to total knee replacement. So this is a posterior guide. You can see the saw is just going through the posterior cut, and this is a normal place. You can very well appreciate that at the posterior part there is a gap between the blade and the guide. So if you drop your saw down on the anterior side, the blade will touch snugly on the posterior surface, and that's the right way of taking a posterior femoral cut. Now, there is a guide. Dr. Gulati has already explained it to you. The only thing you need to take care is that put it in the maximum weight bearing zone of femur. So it has to be in the middle 1/3 of the medial femoral condyle. This is the way. Now, coming to tibial loosening. Now, loosened implant, like in total knee replacement, we look for radiolucencies. However, in unicondylar replacement, unicondylar implants, we have two types of radiolucencies. The one is an irregular, more than 1 millimeter wide radiolucency, which is pathological radiolucency. And we should differentiate between these two because physiological radiolucencies don't cause any pain. They are not a marker of loosening of implant. So we have to look for the radiolucency and migration of the tibial implant. So if you can see that the difference between the the immediate post-operative X-ray and further X-ray is, you can very well appreciate that the tibia has subsided and there is marked difference in the positioning of the tibia post-operatively. So the one relaxing thing which you should know is, although we feel that tibia is a very small implant and all the force is going through the tibia, but in practice, true tibial loosening is very rare. The causes of tibial loosening are that tibia maybe the surgeon has put a very small tibia and it is not sitting on the medial tibial cortex. So if it is on the lateral side of medial femoral cortex, it's not on the hardest bone. It is on the cancellous bone, and that usually causes a subsidence of tibia. So the trick is that you have to put as big ml dimension tibia as possible and put it on the medial cortex. If you are having a shorter implant in the medial cortex, then you should medialize your implant, but put it on the medial cortex so that the weight is being taken by the medial cortex of tibia. And you have to avoid impingement, and cement should not be retained. There should be no retained cement on the posterior or anterior side, because that will cause an impingement, a polydislocation, and it will cause a stress riser for the loosening of tibial implant. Now coming to infection, infection is fortunately the rate of infection is far less than what we see in a total knee replacement. Being a minimally invasive surgery, most of the like 70 to 80% of the normal tissues are preserved, and the vascularity of the knee is relatively preserved. So that actually causes a very negligible rate of infection in UK surgery. Although the principle of treatment remains same for both the unicondylar and total knee replacement. So in acute infection, we have to open, debride, give IV antibiotics. In chronic infection, we have to remove and put a spacer. That's the way we treat infection. The difference between a total knee and a unicondylar is that we are going to like remove the normal cartilage also. So once a unicondylar is infected, we have to remove the lateral compartment cartilage also, and we have to implant a articulating or static spacer for both the condyles. Because if we retain the lateral compartment, it's seen that bacteria survive in the preserved cartilage on the lateral compartment, and the infection is not properly eradicated. So the image on the left side is what is not recommended nowadays. Now, to take home message for all is that it's a relatively different surgery than a total knee replacement. The complications are usually because of surgical errors. Now, in the beginning, individual surgeons can have different modes of failures, and usually it happens that they keep on repeating the errors. The way to improvise is to take guidance, is to do cases, is to learn about unicondylar and do frequent cases with amendment of their prior mistakes. So it is seen and proved that high volume surgeons and centers have very few complications than patients who are having low volume. So the answer is that in a year, people should do at least 12 to 20 cases so that they can like improve their surgical practice. If a surgeon or a center is doing less than 10 cases or 12 cases, then usually the chances of complications are higher because they are not very well versed to the instruments, the alignment, the cuts. And the adherence to the proper recommended technique in the initial few cases is highly recommended. So whatever way it is taught, the instruments, use those instruments, do the surgery as it has been prescribed and recommended. Thank you.
Thank you, Dr. Harish.
Thank you,
Thank you
Dr.
so much
Pardeep.
for a very well informed about the complication of UKR and how to prevent them. Any questions or comment from the faculty, please? So then we move on to the next talk from Dr. Manjure. He will be speaking on past, present, and future of UKR. Dr. Manjure, sir.
Right. Good evening, everyone. I really enjoyed all the three talks, and I think all the three talks, Dr. Gulati, Dr. Ghoota, and Dr. Bageja, they made my life really easy. There's not much for me to say, actually. I just want to touch on my first slide here. The reason I put this about the surgical exams and about the regional advisor is that I'm involved in supporting and providing mentoring to all the overseas surgeons who come here for their training. And if there are any juniors who come here, I would be very happy to sort of support them and mentor them. So happy to take that on in future. answer to Dr. Maini's questions, and thank you very much, Delhi Orthopaedic Association, for really giving me this opportunity and inviting me for this talk. Dr. Maini asked the question about why did you take on unicompartmental knee replacement? And my first stint at unicompartmental knee replacement goes back in 1997 when I was training in southeast of England. And at that time, I did the study, which is a prospective randomized study comparing total knee with partial knee replacement. And this was the phase 2 of the Oxford unicompartmental. And this formed the thesis of my towards my MCH at Liverpool in 1999. I did go on to present this in the BOA, and also coming my original MS and education was from Baroda, which is in Gujarat. And I did present it to the Baroda Orthopaedic Association, and I was very keen to take this back to India at that time. But I think the cost factor was prohibitive, and therefore it took a bit of time to go on. Going back to the history, and I think history does teach us a lot. And if we look at the history, the first unicompartmental was implanted in 1954 by chance in Toronto, when a 73-year-old woman with correctable valgus knee had a cut acrylic prosthesis inserted. And this prosthesis, you'll be surprised, and I was surprised to know that it lasted almost 12 years. Thereafter came the Vitalium in 1964 and the McKeever knee in the 50s. And these all gave good, excellent results. From there on, a lot of materials were tried, tested, but there were a lot of failures. And then we saw a resurgence again in the 70s. So UKR and failures is a known fact in history of orthopedics because of prosthetic design, surgical technique, patient selection, so on and so forth. And we all discussed this in our previous talks and heard how we can counter this. So I've done Oxford, but I've also done other knees like the Corin ones, half knees, DePuy, and some others fixed bearings as well. But majority of my knees have been Oxford. So if you see the history, the first patent for Oxford knee was issued in 1974, and the first knee was implanted in 76. And then in around 82 came the concept of anteromedial osteoarthritis. 1988, the phase 2 was introduced. My study of the randomized control trial between total knee and partial knee was using the Oxford 2 phase 2 instrumentation and implants. In around 1998, the phase 3 started, and we were lucky to use that at that time. And then in 2003, a cementless prosthesis was launched. In 2004, the Oxford domed lateral knee was introduced. I've done a few lateral knees. As you know, we use a fixed bearing. 2009, we had the nickel-free implants being introduced. And 2011 was the launch of the microplasty instrumentation. I haven't been using the microplasty from 2011. I started using it in the last 4-5 years. And somebody did mention about the Swedish study, and they showed that the phase 2 Oxford, which was used, their results were 91% survival at 20 years. And that was a non-originator series, which was published in 2011. So if you look at whatever the armamentarium we have for various aspects of arthritis, somewhere in the middle we have the osteotomies, the unicompartmental, and then the total knee. And as orthopedic surgeons, we have to compare the unicompartmental knee with gold standard, which is still the gold standard, the total knee replacement. Osteotomies, I know in India we do a lot of osteotomies. In UK, we have seen a resurgence in the last few years, and especially in certain group of patients, we have been using osteotomies again in the last 4 or 5 years. So the previous speakers did touch on the indications, and I think it is really important that we get the patient selection right. If you get the patient selection right, the rest of it falls in place. It's really important that the varus is completely correctable in extension, and there is less than 15 degrees of fixed flexion deformity. One of the other factors is intact ACL. There have been a lot of papers where if you have absent ACL and still anteromedial OA, you can reconstruct the ACL and then perform a partial knee. Again, it's a lot of operating there, and I'm not yet convinced. I personally haven't done that many reconstructing the ACL and then performing a uni. Of course, we should have a normal functioning MCL, full thickness lateral, correctable varus, and fixed flexion deformity of less than 15 degrees. This slide was shown by Dr. Bageja previously. I just want to dwell on this a touch. So I don't take stress X-rays, but we do weight-bearing X-rays. And if you see the top line where there is almost complete loss of medial joint space, and if you see the X-ray below, in the weight-bearing view, there is still medial space. And these are the candidates whom you should avoid performing a unicompartmental knee replacement. This form is provided by the Zimmer Biomet company, and I've been regularly using it for the last 2-3 years. Same thing with the ACL. If you map it based on the erosion or the area of the arthritis, then your indications, you would get it right. And if you see the last two lateral X-rays, you can see the erosion right up to the back. And therefore, these are the patients who have absent ACL and really not indicated for unicompartmental knee replacement. We touch on the full thickness lateral cartilage. Some of the top ones, especially the one on the right, where there is a bit of osteophyte on the lateral side, these are the patients you could still carry on with a unicompartmental knee replacement. Of course, functionally normal MCL with no fixed deformity is in the next criteria. Patellofemoral, again, we touched on that, and if there is a severe patellofemoral grooving and subluxation, lateral facet OA with bone loss, these are not the candidates for compartmental. And again, this slide was shown where, and I want to stress this again because it's really important that the posterior aspect of that cartilage is retained, is intact. And with a good quality lateral X-rays with condyles overlapping, you can easily make that out and decide which way we are going. There was a query about the other knees. I personally have now gone for the last 3-4 years with a uncemented mobile bearing Oxford. There is a cemented version available, which I've been using before last 3-4 years, and it has worked very well as well, and I'll show you the results later on. Fixed bearing Oxford, again, the fixed bearing process is whether it be Oxford or any other types, perfectly justified in using those. My colleague, who is again a very high user in our hospital, he uses a fixed bearing and swears on it. So nothing wrong if you have to go and use a fixed bearing, if that's what the philosophy dictates. Having said that, I'll show you the results between the fixed bearing and the mobile bearing, and then you can decide which are the ones you would like to choose. There's also nickel free, so there are some patients who have metal allergies, and sometimes you may want to use those nickel free implants. So as we all use like the MIS, the minimally invasive surgery, with a uncemented tibia as well as femur and a mobile bearing plastic. Some of the indications of unicompartmental, we discussed that, and within those, that's fine. But there will be special situations where you will have to take a call whether you are going to use a uni or whether you are going to go to some other route. So one of the things is medial or lateral tibial fracture, and in very few cases, I have resorted to unicompartmental knee replacement, especially on the medial side. Of course, one could fix these fractures, and then as a second stage, if it gets worse, you could do the unicompartmental. But the special situation I'm talking about is in certain elderly patients where you don't want 2 operations, you want just 1 operation, get done and over with, and mobilize them straight away, because if you fix the fractures, you may have to immobilize them, and then all the problems of immobilization arise. Same thing with high-risk patients who get total knee replacement, and if you sort of expand your indications a bit, then you can do those in slightly elderly patients, and I'll show you later on the results in the NGR as well as my own. Young age is one of the things where you want to decide whether you want to do an osteotomy or whether you want to do a unicompartmental knee replacement. And again, this will have to be decided based on your own experience, but also based on the expectations what the patient has after the surgery. High BMI, a lot of studies have shown that if high BMI, especially I'm talking about BMI about 35, 40, that sort of thing, whether we should be doing unicompartmental. The Oxford group and various other studies have shown that high BMI does not cause problems, but I think one has to be very careful. Especially I have found that women with high BMI do really badly with a unicompartmental. Maybe it's a technical issue which may have to be corrected. The other thing is a high demand knee patients who want to do skiing, want to do racket sports or certain other high demand activities, whether unicompartmental knee is the right one for those patients. So again, the question as to why unicompartmental knee replacement, it is less destructive to the native joint. It preserves the cruciate ligaments. It there's better function, active lifestyle, better patient satisfaction, and I'll show you those with figures in my subsequent slides. A better forgotten joint score, lower mortality rate, and lower complication rate. If you compare the unis with total, the design I think is still evolving. And if you compare that with total knee replacement, we are probably about 10, 15 years or even more behind than that. I think with the advent of microplasty instrumentation and with uncemented prosthesis, maybe we've taken a few steps further. On the National Joint Registry, and I'm sure most of you know, National Joint Registry in UK is the registry where all surgeons in England and Wales, they have to submit their joint replacement data, and it is collated in a national database, and yearly reports are produced, and this has been going on from 2004. There is a longer learning curve. Unicompartmental, as Dr. Gulati also mentioned, it's less tolerant to surgical errors. And because it is easier to revise it to total knee, so it gets revised very easily, whereas revision from a total knee to another one, usually surgeons wait. So the Oxford partial knee is now available with porous plasma spray and hydroxyapatite. It has a twin peg, as we saw, has a mechanical interlock with the substrate. It provides additional early fixation. It reduces the incidence of radiolucency under the tibial components on the radiographs, and also eliminates the possible known failure mechanism caused by suboptimal cementing technique. It's also shown to reduce average operating time by about 9 to 10 minutes because we don't have to wait for the cement preparation and the curing time. Mobile bearing, again, the design remains fully congruent with femoral component throughout the entire range of motion. There's increased wear resistance. There are various sizes available, and the anti-rotation anterior and posterior tabs are designed to reduce the risk of spin out or dislocation, as was mentioned by Dr. Ghoota. I find this slide very important and interesting because ever since I started doing my unicompartmental knee replacement, after I've seen the post-op X-ray, I sort of go and draw some lines and compare it with my other X-rays. It's really important because when you're doing the surgery next time, you would then know what mistakes you have made in the past. And I continue to do that because as we've been discussing a unicompartmental, you can easily make surgical errors, and therefore it's important that you analyze your own X-ray with all the various angles which has been there, which are there. And sorry for the busy slide here, but all those angles in the AP and lateral views, it is a good idea to analyze them for your post-op X-ray. So the randomized trial which we did in 1998-99, similar such trial was done recently. Of course, the numbers are more 250 in each group. Ours were only 50, and they did. Of course, the assessment was a bit more vigorous in terms of Oxford knee scores, EQ 5Ds and SF12s, complications, patient-reported outcomes, and so on and so forth. So if you see the results, 82% of the patients are satisfied with UKR, whereas only 77% with TKR, and similar such results for the knee scores, and also the question to the answer to the question whether they would have a knee operation in future. Am I overrunning, Dr. Bageja? Is it okay for a couple of minutes? Okay, so I just want a few more slides regarding the revision, and I want to take this to the age, compare them with the age. So if you see under 55s, of course, because of the high demand, their revision, cumulative revision rate is slightly higher than the other age group. But I would like to cast your eye on the 80 plus people, and if you see, they actually do really well with a unicompartmental knee replacement. And my point is that if indicated, the plus 80 group will do really well with unicompartmental knee replacement, and I think it should be offered to these people. The unicompartmental may last entire their lifetime. If you compare it with total knees, unicompartmentals have a good outcome, even if you compare with other total knees, if not better. One of the point I want to make is if you see this paper, if you widen your indications, your selection criteria, and if you have more than 25 to 30% of your knees doing unicompartmental, then your results improve. And my percentage right now is about 30%. I'm not gone to 40 to 60% of my knees getting uni. But if you can widen the criteria, the results are much better. Again, this was mentioned by Dr. Ghoota, more than 12 partial knees, the results get better. It's been shown in literature that almost 47 to 48% of the patients are suitable for a partial knee. And almost 48% of the knee have intact ACL. So these are the patients who can easily have unicompartmental knee replacement. And again, if we compare the total knee to a fixed bearing partial knee and to a mobile bearing, the mobile bearing knee are 2.7 times more likely to be satisfied in their ability to perform activities of daily living, and 1.8 times more likely to report that their knee feels normal. And this has been a constant feature in my practice as well. Same thing, the satisfaction with a unicompartmental is much, much higher than a total knee patients. And you can see in the National Joint Registry, the usage of uncemented unicondylar knee is going up quite a lot from 2012-2013. We touched on the failures. If you see, this is this is for the whole of the country, and you can see there is a dislocation and periprosthetic fracture, which is more than the expected and I think there are people out there who are doing less numbers, and therefore they're getting some more complications. Whereas some of the others we have been able to tackle, like the progressive arthritis, aseptic loosening. But dislocation and periprosthetic fracture is one which needs to be addressed and prevented. I want to show you this slide where you can see the Oxford partial fully cementless unicondylar is doing much better at 10 years than any other unicondylar knee replacement. And this includes the cemented Oxford phase 2, phase 3 as well. As far as the patient reported outcome measures are there, there's not much difference between the two. Again, those are the patient-reported outcomes, and you can clearly see the Oxford cementless knee is doing much, much better in terms of Oxford knee score, in terms of EQ5D, EQ-VAS scores. And same thing on that slide. As mentioned, can't reinforce this more. The mobile bearing feels much normal, and patients are able to perform activities of daily living. Same thing, almost 50% achieve excellent results, and this is National Joint Registry. It has been shown that if you're doing more than 30 to 40% of your practice as unicompartmental, your results improve a lot. And I think we all need to understand that and maybe implement that in our practice. I just want to show you last slide. This is my sorry, the second slide. These are my results on the NCR, and I've been putting my data on the National Joint Registry from 2004. You can see my knee replacements are doing much better than the national average, and part of this is because I use navigation. We've been using navigation for the last 15 years. Oxford knees, the Unicondylar, that includes my fixed bearings as well as my fixed bearing lateral, and it's still in the middle. It's in line with the national average, and so are the patellofemoral. I feel that this is likely to improve, especially when the numbers of uncemented knees go up. So just a point or two about the future of UKR. Day case surgery, we've been doing this for the last few years, but now it has got a formal form. And one of the things about day case is to not start flexing the knee immediately. Give few days before you start flexing the knee, before the physio starts, and they do really well in the sense that you can discharge them early with pain relief. Robotic knee, again, I haven't done it, but I think it's on the horizon. A lot of people in the country are already doing it, and I think probably that's the next step. So in conclusion, patient selection is very important. There is a steep learning curve. Knee feels nearly normal, and it gives excellent short-term as well as long-term results. Thank you very much for your attention. I'm sorry if I overshoot the time.
Thank you, sir. Thank you for your excellent presentation, which covered almost complete journey of Oxford knee as well as the future of the Oxford knee, and for your time and participation. Thank you so much, sir. There's only one question from chat box, which is asked by our past president, Dr. Sharad Agarwal. Is there any age criteria for UKR besides the standard indication? We already covered in your slide, but still I will answer this.
No. In fact, my oldest patient I have done is around 89-year-old, and I have a 91-year-old on my list. In fact, the 91-year-old is a Gujarati gentleman who used to walk 3 to 4 miles a day, and now his main issue is pain, and therefore he cannot walk. So there is no age criteria. If they meet the indications of unicompartmental, then I would do a unicompartmental knee replacement.
Any other comment from the faculty or questions?
Yes, Dr. Sanjiv, I am having a question for you.
Please,
since you have already elaborated that mobile unis do very well even in your sitting, then what's your indication of doing a fixed uni?
So
like in which selected cases you?
Yeah, I don't do fixed uni for the medial OA now. I do all mobile bearing. But as I said, my colleague, he just does fixed unis, and he swears by it. He's got very good results as well. But if you look at the literature, mobile bearing unis are doing better than the fixed bearing. So I personally have done it in the past, but I no longer do it. For the last 5 to 8 years, I have not done a fixed bearing for medial side. For the lateral side, I always do a fixed bearing.
Okay. And what percentage of your unis comprise the lateral uni?
Very few.
Approximately.
Yeah, 5%. 5%.
Okay.
It's in fact in the last few years, it's gone down and down. It's I don't know why, but it's going down. The lateral unis are going down a lot. But I would say around 5%.
Usually in our practice, when we see a lateral compartmental OA, most of the times it turns out to be an inflammatory one. And then a lateral uni is like ruled out for all practical purposes.
Yeah. So
and the second thing is we don't have a very good prosthesis for a lateral uni in India at present. So we are yet like, I have never done a lateral uni. So that is one of the reasons for that. Thank you for your explanation.
Thank you.
Thank you, Dr. Manjure, sir. Thank you, Dr. Harish, for the good discussion. Now I invite my last speaker for the today's session, Dr. Kartik Shukla, sir, from Ahmedabad. He will be speaking on UKR in his clinical practice. Dr. Kartik, sir.
Good evening, everybody. I am very much thankful to Delhi Orthopaedic Association for this meeting and invitation. Most of the topics are covered, starting from the right patient selection to the surgical technique to the prevention of complications in UKR and the future and horizons of UKR. So in short, I am going to share my experience, and that will cover the question asked initially, why we opted for UKR. That would be my explanation and my feelings toward UKR. So we started doing UKR in 2014, and this is the 2021. So the basic philosophy, if a surgeon believes in this slide, he will opt for UKR. So if you are ready to stop the progression of a disease and you want to give a reparative gesture to the knee rather than replacing the whole knee, this is the best treatment if timely taken by the surgeon. So naturally, it requires two things, the thought process and the action you want to take for this kind of disease. So to me, as the UKR is quite compartmentalized procedure, unicompartmental or partial, so it is divided into two things. If a surgeon finds it's intellectually exciting, like this dance, Bharatnatyam or any kind of classical dance, then the person will go to attend this function or this kind of dance. And second thing, once you believe this, you have to learn it in the right way, as rightly mentioned by Dr. Ghoota. This is technically demanding. It cannot be learned overnight. You have to spend time. Once you are ready to do the procedure, you have to undergo a technical expertise to do a right surgical execution. As one patient asked me one day, sir, if this procedure is so nice, then why the surgeons are not doing this regularly? And actually, I was completely silent to give him an answer, and then I studied the literature and find out why this is not happening. And then I came across this wonderful slide. I forgot the name of a surgeon, but he has put this in a JBJS. Can we all perform PKR? And the explanation was very good. So on one side, there is a technical excellence, and on opposite sides, this is a sense of caring and service. This is what I told you, that intellectually exciting and technically demanding. So this is on, I feel myself in this chart or table. The surgeons, as I was doing TKR, and I was very happy, I explored navigation in almost 2008 and to strive for the excellence in TKR. And we had a wonderful result, but I felt myself as a disconnected surgeon. And so from my journey, start from disconnected surgeon to a nice surgeon to a competent surgeon. And then I feel naturally we do a good job when the patients comes in time and we can offer them a best solution. So as rightly mentioned, the criteria, that was a lot of problem with the selection of a patient. So initially it was like more anatomical criteria. So I never understood this because varus less than what? How to measure the varus is a big problem. Standing, one leg standing, varus stress view. So I never knew how we measure the varus in the right way. Flexion deformity. So if it with in a clinical OPD we measure the flexion deformity, or we give local injection and we measure, or after anesthesia we measure the deformity, and so that is also confusing. Weight, how we can guarantee that it won't increase after the patient goes for a surgery. And activity level, again, it's how to decide the activity level. There may be a gross criteria, but we cannot have a very clear picture to decide upon all this. And the tibia vara had added a lot of new confusion to the measurements of the axis and the varus. So better we stick to a more clear, crystal clear physiological criteria. When there is no number, there is no confusion. Pathology is well understood when you select the patient. simple radiological documentation of a pathology. Preserved physiology is also confirmed, so it is not a neglected part. So you confirm that physiology is preserved in the rest of the knee, and the wrong contraindications are rectified. So our learning curve starts from 2014 to 2021. So initially we had very limited understanding. We are seeking expertise. We have fear, questions, and concerns for longevity, and naturally we do have very less patient. And now almost we have 40 to 50% of patient, and we have very much optimized surgical team, and we do very regular Oxford procedure. As this slide is already discussed in first lecture, so where you stand as a surgeon decides your number of patients you operate. So if you select the first, you are in 10% patients you do Oxford, you extend it to moderate, you go up to 30%. And if you go up to the last, you can have 40-50% of patient. So you decide how the anteromedial osteoarthritis as a spectrum works. Now there are a lot of confusion, so I will summarize very shortly about this. Very clear for the beginners actually. If the standing X-ray, there is no bone-on-bone arthritis, you have to go for a varus stress view because you have to demonstrate bone-on-bone arthritis. So again, on varus stress view, there is no bone-on-bone arthritis. This is not a patient of UKR. There is some mechanical derangement or something else, but not a uni patient. So if there is a bone-on-bone arthritis, again, it's a UKR patient. But if the bone is there on standing X-ray or with a varus stress view, you have a possibility of tibial translation. So if there is no tibial translation or translocation under the femur, straight away, it's an AP X-ray we are talking about is more uni-favoring X-ray. If there is a tibial translation on the standing X-rays, you have to go for a valgus stress view and you have to see if there is a correction or not. If there is no correction, it is not a UKR patient. It's a fixed deformity, varus more than 15 degrees or something like that, and there is a TKR patient. If it is correctable on valgus X-rays, you can think of UKR unless you see the lateral X-ray. As already mentioned in so many lectures, this is the most important thing you have to find. So X-rays, a proper X-ray in a lateral view is most important X-ray to decide the Oxford or partial knees. So to summarize all the previous lectures again as a revision, there are 4 things because as Dr. Ghoota has rightly mentioned in his surgical techniques, how you hold your instrument with your pulp of fingers or with your entire hand will determine the longevity and outcome of the patient in the long run. So proper exposure, number 1, precise tibial cut. Spigot science is a miracle as Dr. Yash Gulati sir has rightly mentioned. Once you understand the spigot science, it's a simple job, it's a miracle, and you can balance your knee in a millimeter and accurate gap balancing at the end of a procedure. So I will show a few cases of mine. This is one of the very extreme case we did almost 6 years back. 44 female, bit obese, very, very young for the age, but very gross varus and difficulty in day-to-day life. You can see the clinical photograph. And this is how she is walking. And this is miserable and horrible as well. So initially we thought of doing TKR in this patient because she has everything. She has a varus, she has a deformity, she has loose bodies. I don't know how the patella is there, the ACL, the defect, lateral thrust, and all the difficult situation. And this is extreme case of anteromedial osteoarthritis. But as rightly mentioned previously, you have to see the lateral X-ray. And if you find still the lateral posterior cartilage of the tibia is intact, that means the HCL is good. This is the valgus IATV images we have evaluated, and we did, and you can see the absolutely pristine lateral compartment on both the side and absolutely very good ACL. Minimal tibial resection is the key here. It is so much deep, so it just flush with the defect to make the tibial plateau flat. And you can see a thicker 4 millimeter of the bearing used in the right side, but this is almost 6 years back we did, and she is absolutely doing good. And as the clinical results Dr. Yash Gulati has mentioned, it's a mesmerizing results you can see when you see the patient. And you can see this lady back to normal life. And second thing, this is a spontaneous osteonecrosis case, very rare case of tibia spontaneous osteonecrosis, hilt version of it, with isolated medial compartment arthritis, instability and deformity. And again, you can deal it very well when you can use the mobile bearing or any kind of unicondylar knee replacement. You can avoid total knee replacement surgery. So when we see the anteromedial osteoarthritis, there is always at the red. So to make beginners to understand these are the factors we need to see from A to T. So age, bow legs, chondrocalcinosis, deformity, and whatnot. But this really you need to see, but most of them are not going to give you a lot of trouble if you understand the selecting right patient very well. The flexion deformity is always a concern for the surgeons. So most important thing, the flexion deformity, what is causing flexion deformity? If you see the lateral X-ray, anteriorly there is an anvil osteophyte which is preventing the full extension. And when you do the surgery, you will get an on-table full correction of it. But if it is a contracted capsule at the back of a knee, then it will take some time, and you have to reassure your patients that this will take some time, but definitely it will go away. Previous high table osteotomy indeed a contraindication because of multiple problems, but we came across a wonderful patient who had undergone high table osteotomy on one side, and one side TKR, not happy because some other surgeon has operated patient, continues with the pain, and he came for any other option than TKR. The tibial osteotomy is already done 10 years, the knee did very well, and she ended up in a medial compartment arthritis because of the loss of the correction, and there was fortunately no hardware, no other scar and healed tissues, and we did this almost 2 to 3 years back, and she is still doing very good, and now I think she will have a wonderful result. But this is once in a while scenario, but this is just to show that this can be done. This is a case when you can see most of the time we feel it, this is like a ligamentally unstable knee, but if you see the lateral spine of the tibia, that is giving a wonderful preventing measures to stop translating the tibia on the lateral side, and that is a natural try of nature to prevent the further damage to the knee. And this was a lateral X-ray. The ACL has to be good, and we operated this patient with the Oxford. And now you can see, as Dr. Yash Gulati has rightly mentioned, that all the ligaments will come under the precise tension. You are not over tensioning, you are not under tensioning. You can see the space between the femoral condyle and the tibial eminence, because your ACL, PCL, MCL, and lateral collateral, all 4 ligaments will restore back to its normal physiology, and that's why the knee works very well. The stiff knee is again a problem sometimes, but again we need to find out the cause of a stiff knee, whether it is osseous, it is ligamentous, or the fibrosis that is giving a problem. So this gentleman is comparatively 45-50, and he had both the cause of the reduction of the movement. The full extension is prevented by the anvil osteophytes, and the posteriorly the flexion is prevented by the femoral condyle osteophyte at the back of the femur, and he regained a wonderful motion after removal of this bony spurs. We did few cases when there is a young patient and they have neglected their ACL deficiencies, and they presented with ACL deficient needs. With the arthritis pattern would be more posteromedial rather than the enteromedial because the ACL is gone. And we did a simultaneous procedure in this patient with reconstruction of ACL and along with the partial knee almost 4 or 5 years back, and this is almost 6 years follow-up, and this gentleman is doing very well. So in elderly patient, if there is, as rightly mentioned recently in the last topic, that elderly patients are the patients who really do very well. So we had one patient where there is a fixed varus, and we are not sure about the ACL in this patient on this knee, and we opted for the fixed bearing design. I would have used a mobile bearing as well without any worry, but we use fixed bearing, and this patient is doing very well because he's so elderly with lots of medical issues, and twice he was admitted in ICU because of even minor procedures in the past. Obesity, as mentioned, is not a problem, but as rightly mentioned, that female patients do carry some risk. So the minimal, very minimal tibial resection is the key. Because if we say osteoarthritis, there has to be sclerosed strong bone in the tibia and the femur, and that's why less than 3 millimeter of cartilage loss is not a good indication. Bone-on-bone arthritis, especially when you are operating obese female patient, but it can be done very easily. And what we found out that if these 3 things make your procedure very comfortable. Number one, your orthogonal position is very important. Sometimes the position gives the tibia tilted varus or valgus or rotation kind of placement, so that will disturb your visual impressions on table. So orthogonal position, the tourniquet has to be applied very high, and proper flexion needs to be documented so that that makes surgery easy. We do all our Oxford, every single case in a hanging leg position, and that gives us a lot of peace of mind as well. So anterior knee pain is always confused with patellofemoral arthritis, but I want to add few things from my side. So if you see this chart, the distribution of pain in front and back in anteromedial osteoarthritis varies. It is never a thumb test or a localized pain you see on the medial joint line. It is definitely, it has to be generalized pain, anterior pain as well as medial pain. But anterior knee pain does not mean patellofemoral joint arthritis. Patellofemoral joint arthritis may not have anterior knee pain, that we know very well in total knee patients. And what I feel that there is nothing like ligament balancing patellofemoral joint. There is no ligament we need to balance. So the osteophytes needs removal for ligament balancing, that we know in total knee. Here you can leave the osteophytes as it is because they are not going to give any problem. If there are loose bodies, that has to be removed. And this is my personal feeling that reparative gesture of uni is really best appreciated by the patellofemoral joint, because anterior knee pain completely goes away after the correction of the varus, flexible varus deformity. The second thing, single versus bilateral Oxford. We do lots of bilateral Oxford. We prefer split table. Avoid hanging leg for a long time. If there is a beginning of a practice, better to do 1 by 1 stage procedure, one surgery at a time, and 6 weeks or 8 weeks of this duration in between. 2 stents, we use both the knee in Oxford hanging leg position, and one person can just do closer and the second knee can be started. That is the advantage of Oxford position, and we have excellent outcome. But in our series, what we have found is the second knee has become an independent risk factor for bearing dislocation. I will come to that very shortly. So this is our series of almost 2,000 patients we had operated in last 8 years. Our youngest patient is 38 years. Our oldest patient is 92 years. So I think the age is not a criteria to select. And our most obese patient is almost 135 kg, very high BMI. So this is, I'm going to put in this way, that overall dissatisfaction or the complication we can say is 0.65% in our series, and the ratio of female to male is 10 to 3. So to put the data in a nutshell, one patient had a stiff knee which needed arthroscopy, and this patient did very well. We don't need to revise the patient. One immediate post of infection, uncontrolled diabetic lady, and just need a lavage, and she did very well. One lady converted to rheumatoid. After 3 years, she developed chikungunya, and then she developed rheumatoid arthritis, and we need to revise it for the total knee. There is one tibial fracture, and that we need 2 tibial fracture, and one was fixed with a plate, and another is revised because she was not a competent patient, compliant patient. She had a lot of medical problems and psychiatric medication with repeated falls also. So finally, the revision TKR was done. We have 6 bearing dislocation. Out of this, almost 4 were traumatic. The 5 we were able to reduce with the same or one size up bearing, and one patient had 2 dislocations, and then that patient needed revision. Anterior knee pain, one patient had anterior knee pain, and she needed a small procedure. I will show you the video of what has happened to that lady. So overall, we had almost 2,000 patients. We have 8 years of follow-up. 11 patients just needed resurgery. Revision surgery was just in 2 patients out of 2,000, but male to female ratios, like female patients are more in 10 to 3, and total complication is 0.65. This lady, when seen by another surgeon, advised revision surgery. So fortunately, she came back, and we found out that there is a reach of the patella, which is more like a lateral patellar compression syndrome, which is giving her a trouble. She was able to walk 5 kilometers, but she had difficulty in climbing steps up and down. And we just removed the osteophyte from the femoral condyle and the patella, and that she absolutely went home in 3 days without any problem. So the take-home message would be, uni is not a replacement. If you believe that, you can start exploring this, and it is more reparative in gesture to the knee. You contemplate and you experience yourself this truth. Be careful with the female gender. They carry 3 times higher risk in our series. Bilateral procedure, it is an independent risk factor for bearing dislocation we have. Second surgery needed in second knee. And sorry, I just need to. That was, I think, the last take-home message. And consistent team. This is what I felt is very important, because like good quality X-ray is very important, and has been told by many surgeons. But you must have a very consistent team of people working for this procedure, and you will definitely have a wonderful, good result at the end of a procedure. Thank you so much for your attention.
Thank you so much, Dr. Kartik, for a wonderful presentation and showing a lot of cases to us. So we complete the session today, and the session is open for discussion and question and answers. Any question from the any executive members who are attending here? Any cross questioning from the faculty from itself? Any point to be taken care? Dr. Gulati, please, sir. Any comment?
Not really. I mean, I think we are all saying the same thing, fortunately. Does anybody know how many surgeons in India actually do uni regularly? Approximate number?
No idea, sir.
And Dr. Sanjiv, what is the percentage of knee orthoplasties in UK now that are kind of unis? I've heard about 30%. Is that correct?
Yeah, so it varies from unit to unit, but I would say around 20 to 25%. There was a phase between 2014 to 2017, or even 2012 to 2017, when the unis got a lot of negative publicity. A lot of papers came out in the British Orthopaedic Association where the results were inferior, and therefore people went away from unis, and there was that sort of period. But now in the last few years, you saw on the slide that the number of unis have gone up. So I would say around 25 to 30% is the estimate. Of course, what happens is, because the system is slightly different, where the patients are referred a bit late, they have a sort of other treatments. So it's possible that some of them are coming late to us. But on an average, 25 to 30%.
And would it be fair to say that majority of orthoplasty surgeons in UK are now doing unis?
No. So I'm sure you heard of getting it right first time. This is the project all across England, and we had so all units are very closely monitored. So we had a visit about 4 years ago, and it was sort of told to us that only couple of people should do unis. So I was one of the high user, and therefore 2 of us now do unis in our unit, not everyone. So if somebody does more than 12, then they are allowed to do it. Otherwise, rest of them are not allowed to do it.
What would be the approximate percentage of surgeons in England who would be doing?
I would say around 40%.
Okay.
Yeah. Because some of the old timers, where they are doing just total, they don't do unis at all.
And people who don't do it, do they find the reason to criticize it, or they accept it as a good procedure now?
So they now, my colleagues refer the uni patients to me, but some of them, what happens is, especially if the uni is painful, they revise it very quickly. They jump on it and revise it quickly, and that has been the criticism, that because it is easier to revise the uni to a total, the more unis are revised. And I think the message is going out that that should not happen. So that is also being monitored now very closely.
I think this is a very, very valid point he has mentioned. So I think I have started saying my patients that if you have any pain, at least just call us once and just don't jump, because I had that lady was immediately offered that this is a very bad procedure and you have to revise it with a total knee, and all these stamps and sleeves and rods and everything was explained, because to begin with you had undergone the worst procedure on your knee. And fortunately, she came because she was from Bombay. She came to us, and we just ended. We made this small procedure, and she is absolutely fine. So what I felt that I always ask the surgeons, like Dr. Yash Gulati is asking very important question, because if I know someone, so I can tell you better you go to that surgeon rather than even coming to me, because he knows about this procedure and he can justify. So even rather I am seeing that patient or that surgeon is seeing the patient is going to be the same thing, as we all are talking the same today almost. So that is very important to begin as an initiative, that surgeon is knowing about everything, about the physiological radiolucencies, metaphyseal, post-operative pain. And so that really makes sense. Otherwise, this uni can be criticized very badly. And that has a very negative impact in the society, that this is not a procedure you should undergo.
I would like to add just a personal experience of mine. So, as Dr. Maini was asking how we started doing unis. So, way back in 2012, I come across with a patient who actually had a uni done by some surgeon in Bombay. So later on, she was shifted to our city, and that uni was also revised after 10, 12 years of time. So she came to me to get her normal knee operated, like the unoperated knee. So she asked me if I can. She had her old X-rays of uni. It was a fixed bearing uni done by some surgeon in Bombay. So she was a Muslim lady. She asked me if I could do such a procedure in the other normal knee, and she was like she could compare the difference and outcome in both the knees together. Like she had a uni for 10, 12 years, and then later it was revised to a total knee replacement. So all the time she was asking me that if the other knee could be operated by the same implant, or I can do a similar procedure, similar to what she had 10, 12, 13 years back. And she was comparing the two processes together. After the uni, she was able to kneel down for namaz, and she was a Muslim lady, so she could do all her daily activities with the uni itself. And after the TKR, she was like restricted to certain activities, and the pain also was there for a number of months, and all these things. So looking and analyzing that patient was the actually key factor for myself. And I fortunately 2 years back I did the Oxford course in England, and that was one of the reasons that I could like uh, venture out in a uni kind of thing. And that was the like I did the first uni on that patient itself. And she was like very gratifying, and she uh, kept coming to me after 4 5 years with more of her relatives, so that they can also be operated. And that was the turning stone in my career, where I started doing unis. And that patient, actually, we as doctors, we also learn from our patient. So she was the patient who could intellectually compare between the two processes, and she could tell me the approximate outcome and satisfaction of that same particular patient. So she was the turning stone in my career, and that was a very good experience. So after that, I've been doing a lot of like surgeries, and I was so convinced with her statement that I could venture out the first case of mine. And that was the really good experience.
I want to ask one question to all the faculties. The case selection is very important, but in your practice, how many time it happens you're gone for UKR and you're shifted to TKR in intra findings? How many time it happened?
See, Dr. Bageja, it happened quite a number of times in my initial years. Like we counseled our patient for both the procedures, and say about 20% of the cases, I have to change my judgment per operatively. But with the coming years, with growing experience, with the way patient walks, the way we examine, the way they are investigated, the analysis of a better valgus stress X-rays, the percentage is still like around 8 to 10% of cases. It has drastically come down. I would say we actually come across, we decide per op that this is the case when we need to change our judgment per operatively, or this is the case when definitely I'm going to put a uni. So it has come a long way after that. And now I am like very much able to predict that this is a patient who is surely going to receive a uni. Now, one very important thing which I would emphasize on this is I never counsel my patient that you will definitely get a uni or you will definitely get a TKR for your arthritis. The reason is once you commit to it, you are like bound to operate the same like you are bound to do the same procedure on that patient. So still I practice the same practice which I was doing 10 years back. I counsel for both the things together. That gives me a leverage to use a uni in a severely arthritic knee also, because sometimes it happens the reverse way. Sometimes the x-rays looks very bad, and when we open it, it seems that the arthritis is more concentrated on the medial part, and that can act, that same patient can actually receive a uni. So that is an added advantage, and that gives us a leverage that we can use both the implants to the satisfaction of the patient itself.
Thank you, sir.
I just have a little comment or question, whatever we want to consider it. The biggest advantage of uni compared to total seems to be the feeling of having a more normal need, the higher satisfaction rate. If that is the given sort of idea behind it, then should implant longevity be the outcome measure of the success of the procedure? If somebody has early arthritis, is in a more active lifestyle age group, which probably will be a relatively younger patient, should we really be considering the longevity of the implant or revision rate for that matter as really the outcome measure of the success of this procedure?
So, Dr. Manjure, you will take it?
See, I would like to say in my practice, what we consider like Indian patients are very, very demanding. Their like surgery is a big task for them. Surgery is like some people might say that this is the end thing and they might not live after that. So considering any surgical procedure, I would say if that procedure is going to last for at least more than 5 years, that is worth doing it. And if it goes beyond 10, then the patient is going to be very satisfied, because the patients we get in India after 60 years of age, they are having all the comorbidity. Maybe they are having uncontrolled diabetes, hypertension. They are usually post PTCA. So most of them are having their daily activities restricted, or their life expectancy, which is it is like near to 10-15 years of time. So I think uni for them is a very good procedure. It makes them less vulnerable for surgical side effects. It gives them a rapid rehabilitation, and the peri-operative risk of surgeries they are restricted to the minimum. So I think there's no harm doing a uni when we are like 100% sure if you do a uni correctly, it is going to last more than 10 years of time.
So I think Vikrant will ask you something else, is it?
I think the question I have, or should I say the conundrum I have when I'm looking at this patient in the clinic, most of the time the patient that you will probably be fighting this decision making is the early arthritis patient. Should I take the chance on him, do a partial, but I still have to tell the patient, look, there is a chance that you might need a revision because you're 55, somebody active. Are you ready to take a chance that it might need to be revised? The point is that if we are setting the same rule for the success of the procedure like we have for total, then we are bound to fail, because there are other reasons why this procedure is more likely to fail, because you're a younger active patient. But the whole idea or whole advantage I see of the procedure is that the knee feels more normal. So should I not do this procedure in that age group where the person is more active? The expectations for him is that his knees should be a little more normal so he can do things.
Vikrant, you can specify some age Because active at your US is different, active in India is different.
Yes,
yeah?
and I think it's not so much age per se that defines the activity level, but there are people who are in 80s and my partner here, he's 77. That guy rides 40 miles a week of bike, healthy as hell. So the question is the outcome measure we have in terms of the failure of uni as the factor to say whether the procedure is successful or no. I don't think it is the right endpoint for a uni than it is for a total. But the way we measure the success, like in registry data or anything, is always the same point. What is the revision rate? But that's not the right endpoint. Shouldn't be the right endpoint to decide the success of the procedure, because the goals are different. What you're trying to achieve with that.
Yeah, I completely agree with what he's saying, that what should be the endpoint? The normal satisfaction means feel good factor after the surgery is the one point, that no doubt about it. But I would like to add that the revision for the knee, total knee, and the revision of this partial knee is quite different. So partial knee revision is cause dependent. What is the cause of revision? Like someone did a tibial fracture on table, and that is a catastrophe. So if to revise that is something very challenging and difficult task. But like someone is coming after 15 years of procedure and patient had a loosening, I think that can be easily be revised rather than 15 years of total knee patients revising. So even if we consider endpoint, the longevity of the procedure and the end result as a revision, the ease of revision again, and to add on with this bone loss, augments or metals you need, and the comorbidities you need to consider in advanced stage, is definitely this surgery should be considered rather than the total.
One thing which you are mentioning, like you are saying that in young arthritic patient, the uni is going to be revised sooner than what it is going to be in a 80 years male or patient, right? Because they are highly active. But don't you think that the same is going to happen with the total knee replacement if it is done at a younger age and in a highly active patient? And if it is a bone-on-bone arthritis, we don't have the third choice. Like these are the only two choices we can offer to our patient, right? So if we are going to do a TKR in a younger, highly active patient, it is going to be revised sooner than what it is going to be in a 70, 80 years patient, right? Now, at the cost of doing this surgery in a younger patient, you are providing him a life which is which is more active, more satisfying, preserving his useful, youthful, productive years of life. So why not a uni? Why to give him a TKR and restrict his daily activities and give him a more less productive life?
I completely agree, and I think the statement I'm making, I don't want it to sound like a debate. It is not that I'm trying to justify against uni. It's not that. The system I am in, and especially as other youngsters who are watching it, it's a lot easier for an high volume surgeon to do a lot of things. But a younger surgeon who doesn't have that much of a volume, when things fail, like you just mentioned, some of the speakers, the person goes somewhere else, and if that person is not somebody who does uni, he jumps on criticizing you for having done the uni, and you're sort of losing your reputation in the community or somewhere. So there is a hesitance. The reason being is that we are holding partial to the same outcome measures as total. And the data we have so far, if somebody wants to debate it, is that you can't show the uni and the longevity of the uni in the same light as total, because we just don't have that much data. So you're always on sort of a back foot trying to justify uni versus total, especially if your patient ends up to somebody's clinic who doesn't do as much uni. So the point I'm trying to make is, when we are trying to discuss this uni versus total to a patient, should we not approach it like saying, look, historically the data suggests that there is a high risk of failing of uni. It is not the procedure that fails, because most of the time we know the failure, as we call failure, with the endpoint of revision being the point, is because of the progression of arthritis and the 2/3 of the joint still there. So yes, you can educate the patient and all that stuff, but that's besides the point, because once you're held sort of in the or being kind of discussed about what you did and what is the outcome, it just becomes harder for somebody younger to explain. So should we not approach it in our discussion, as you guys, faculty members, you're going to be presenting it and talking and probably convincing a lot of people based on your experience to jump on the uni thing now. Should we not say this, that look, the failure rate may be higher, but there are other reasons for it. But why we're doing it is because you are giving the patient a time frame where he is having a more active lifestyle because of that age group, where the knee feels more like a normal knee. Even if you need a revision, it is not that bad. And by the time you might be in the 7th decade of your life, your toll on the knee might be much lower. So a revision 20 years later, 15 years later, but those 15 years having a knee that works just like a normal knee. If I sell like that, and then patient makes a decision, I'm sort of offloading myself from that stress of having a failed procedure, so-called failed, based on the criteria we have for total rather than partial knee.
I think you hit the nail on the head, because if you look at, this is already happening, because if you look at the joint registries, previously the joint registries when they started, and I don't know whether US has a joint registry, but most joint registries when they started revision as the endpoint. But now, if you saw my slide, they have included patient-reported outcome measures. And patient-reported outcome measures includes all these aspects. And therefore, if the patient-reported outcomes are better, then obviously that procedure is much better. The outcome is much better. But even if you consider revision as an endpoint in unicompartmental, you've seen in the last 5 to 10 years, that has also matched the total knee, or even in some implants, it's better than the total knee. So a combination of patient-reported outcome measures as well as revision endpoint is definitely arguably the point to take forward, that why we want to do the uni in a rightly indicated patients.
And that brings me to the last point. I will stop after that. Is that like all the senior members, when you are talking about these procedure as such, I would be happy if it is presented in this manner, so that the junior faculty and all people who want to do it, they kind of understand. Look, sell the procedure like this, not try to justify it other way. Sell the procedure like that. The outcomes are getting better. What you are trying to give the patient is the time frame where they can actually have a more productive life as compared to a total. Selling like that is going to be a little more justified way of, it's a better justification of the procedure. And I think it will come from senior members much easier for the junior team to carry forward.
I think one has to have a conviction oneself. If I have this conviction that uni gives better results, and as Sanjiv said, the longevity is the same, if not better, then I don't have to be apologetic about offering this surgery. And I don't have to feel guilty, why am I offering? I should be buoyant about offering that surgery. But I can assure you, if a surgeon tells the patient that, oh, you'll have a little better quality of life, but you need this revision sooner than the other operation, I can assure you 100% of patients will refuse to have the procedure done. So I don't think that will sell. So, but if you have this conviction that you are offering a better life and better and the same longevity, then you should have the courage of your conviction. But the other will not sell. Nobody will accept it.
And why are you convinced that the uni will last less longer than a total knee replacement? What's the reason for that? It has
No,
been
it is not.
like,
It is not the procedure. It is just the age group because I know the
But
accumulated
that'll
stress on
happen.
the bone.
That'll happen with
younger
the
people
as well.
will have a revision of a TKR also. That's what we are
In
saying.
fact, that will last lesser because there is so
Yes.
much of surface which is there to be loosened.
Thank you so much.
And that revision will be less satisfactory after a total knee replacement for a younger patient.
Thank you, Dr. Vikrant. We'll take another question from another audience. Dr. Shah Agarwal is asking one question, Dr. Gulati. He's asking STO versus UKR in a relative younger patient. Is there any difference in indication?
Sharad, hi, how are you? Now, the thing is, the indications of HTO and uni are a little different.
Yeah.
As I think 3 or 4 speakers repeatedly said that uni is meant for bone-on-bone OA. And I think HTO is meant for not bone-on-bone OA in younger people, if you want to do it. And HTO is an excellent operation. And with the current HTO being done with fixator in a very regulated manner, I've seen some wonderful results. So I would reserve that for active young people who don't have bone-on-bone arthritis, or people who can't afford uni, or people who are manual laborers. And in them, I will offer them HTO.
Thank you, Dr. Gulati, sir. Any other comment from faculty? I think there is no more question from chat box. Any other comment, Dr. Vikrant or anybody else? Dr. Harish?
I'll just add something. During my fellowship, I had one time did an undercut with my recip saw. I went under the middle, just over the just under the spine, and I didn't have a good remarks for my my mentor. So after that, what I started doing, or I suggested, was that I actually started using a pin. I put it right at the corner where I want my recip saw to stop. And I changed the angle also where I wanted. That way, when I'm running my recip saw, I hit that pin and run the risk, or don't run the risk of undercutting. I don't know if anybody's using that or have some improvisation in the jig itself.
I'll tell
in my
you.
practice, I put a vertical blade at the vertical cut.
See, I do it little different. I use the slotted shim for the horizontal cut, and I take the horizontal cut first. Okay, so that completes your horizontal cut, and I take the vertical cut over that slotted shim itself. Okay, so once my saw is deep down, there is still a bone which is like connecting both the cuts together. Okay, I remove that slotted shim, and then I just cut it with minimal force. So that removes the bone which is left behind, and you will never end up putting it more deeper than required. You got it?
Mm-hmm.
So do the horizontal cut first, put the slotted shim, take the vertical cut over the slotted shim. You will still have a bridge of bone which is connecting both the cuts together. You can either cut it by way of, like, you can just run your saw with your hand, or you can just put it with minimal power. That will prevent vibratory forces from going down.
Right. If there's no more questions, so thank you everyone, all the faculty to be here with us in the evening, and goodbye for the evening. Have fun. Thank you so much, Dr. Manjure, Dr. Gulati sir, Dr. Kartik,
Thank you.
Dr. Harish, for their
Thank you.
evening spent with us. Thank you so much.
Thank you. Thank you.
Thank you.
And thank you, Chetan,
Goodbye.
Mr. Chetan from OmniCurious for the show. Thank you so much.
Thank you, Dr. Pradeep. It was a wonderful lecture today.
Thank you so much, Doctor. Thank you, Dr. Ashok Shyam, for OrthoTV support also from your side, from Pune. Thank you so much. Thank you, sir. We'll meet very soon again. Maybe in the annual meeting of DOA. I'll contact you again if they permit me to have a 1 hour symposium on
I think it
partial
would be
knee
very
replacement.
nice if you have one,
Yeah.
Yeah.
Thank you, sir. Thank you, sir. Thank
Thank
you.
you.
For Delhi, we can even
Bye-bye.
come physically. Bye bye.
Thank you.
Bye-bye.
Thank you.